Okay, so we talked about this is the second video for the GI meds. The histamine 2 receptor antagonist is going to antagonize the parietal cell from releasing the H2 receptors because, or histamine 2, I should say, receptors because we're trying to diminish the amount of gastric acid that they have to deal with. So they're also used in conjunction with antibiotics, which we said the National Council had decided, or that committee that was put together in 97, that yes, we needed to put antibiotics with them. Let's see. Adverse effects of our histamine 2 blockers, which would be all of these over here: Tagamet, Pepcid, Exid, Zantac. There's many more, but those are the most common. Low libido and impotence, especially with Tagamet or cimetidine, may block androgen receptors, resulting in low libido and impotence. There's central nervous system effects, and you can read them anywhere from lethargy to confusion. Effects just like anything else, seen more often in the elderly with kidney or liver disease. And, you know, that's not hard to figure out. We know the kidney and the liver are our excretory organs of getting rid of meds. And avoid use with elderly, especially cimetidine, the Tagamet. And again, we have to educate with this, the low libido and impotence, because they can try other ones. We don't want them to stop taking it because we know that they could be at risk for bleeding or a blockage in their belly. Yeah. Okay. Medication reactions with these histamine 2 receptor antagonists to diminish our gastric acid. We have warfarin and phenytoin. Well, warfarin is Coumadin. It's a blood thinner. And phenytoin is used for, it's Dilantin, is used for seizures. So may be inhibited with cimetidine. These are high-powered drugs here, a blood thinner and anticonvulsant. So we'll need to increase the dose of these drugs if they have to take this drug. Antacid concurrent use can decrease absorption of the histamine 2 receptor. So advise, now that we know that, advise the patient not to take an antacid an hour before taking one of these, or give these first and then give the antacid. So with warfarin, and again, that's Coumadin, monitors for signs of bleeding, and we'll have to monitor that PT level or INR level and adjust the dose. And that's why, again, they may use Xarelto instead, because they don't have to monitor that blood level. Okay, so nursing interventions, client education, all of them can be administered IV for acute conditions of these H2 receptor antagonists. Suggest that the client eat 6 small meals rather than 3 large meals a day. Just to, you want to keep coating that stomach instead of it just being empty, so that it can be under attack from the hydrochloric acid. Obviously, avoid smoking. It's another ENE. It's going to constrict blood flow there, and we know blood flow is also needed for a factor to help. It's a defensive factor for the gut. Encourage always the client to avoid aspirin and other NSAIDs, because that can help them bleed. Unless they're taking low dose aspirin, then they're not going to worry about it. Medication regimen can be complex. They may take 2 to 3 different medications for an extended period of time. It takes a while to get an ulcer, and it takes a longer time even to get rid of it. Teach client to notify doctor of any signs of obvious bleeding. That's the biggest thing. I should have bolded that. So underline that. The biggest thing, especially with the elderly, they can have slow bleeds in the gut and not even know it, and then all of a sudden they're in trouble with their hemoglobin hematocrit. Okay, so now we're going to look at our proton pump inhibitors. And these are the very, the most, I'm looking for, the most effective drugs for suppressing secretion of gastric acid. They're used for gastric and duodenal ulcers, GERD, which of course you know why we say that, because it's gastroesophageal reflux disease, where acid is just continually coming up and burning the esophagus high up. All of these drugs are very well tolerated, and selecting a PPI is based largely on cost and prescriber preference. Insignificant side effects and adverse effects with short-term use, so that's really great. So what do? They reduce gastric acid secretion by irreversibly inhibiting the enzyme that produces gastric acid. So they've gone a step further. They're right at the whole enzymatic reaction at the cell receptor site. So they reduce gastric acid secretion by irreversibly inhibiting the enzyme that produces gastric acid. And I'll say it another way. They act by blocking the last enzyme in the system that actively transports acid from the gastric parietal cells into the GI lumen. Hydrogen, potassium, there it is. I knew it was somewhere. Hydrogen, potassium, and adenosine triphosphatase, also known as the proton pump. So the proton pump is hydrogen dash potassium dash adenosine, adenosine, triphosphatase, also known as the proton pump. So again, they act by blocking the last enzyme in that system that actively transports acid from the gastric parietal cells into the GI lumen, and so that it goes all throughout the stomach and then the gut. And here they are. Very, very powerful. And there's the equation there, inhibiting hydrogen, potassium, and that ATP is adenosine triphosphatase, the enzyme that makes gastric acid. Prilosec is probably one of the ones we see more than any of them. I don't know why, but this one is given. The Nexium, I'm familiar with, and Prevacid, very, very powerful. They all work very, very good. A suppressant of acid secretion, used for duodenal ulcers, gastric ulcers, erosive esophagitis from GERD, and for long-term therapy of hypersecretory conditions. There's also a condition called Zollinger-Ellison syndrome, which is that, and I don't really address it in this PowerPoint, but it's long-term therapy of hypersecretory conditions. Again, not to be a secret, but that it's secreting a ton of gastric acid. It's called Zollinger, Zollinger dash Ellison, Ellison syndrome. Within 2 hours of taking these drugs, 90% of the drug is working, but they do say don't use these drugs for more than 8 weeks. Long-term therapy can cause gastric cancer. There's a lot of indecision about this. They said that in the beginning, and now they're kind of on the fence about it. But what they said was gastric carcinoid tumors have developed in rats given Prilosec for 2 years, but they were giving them probably an adult dose. So if you need it, I would take it if there's no cancer in your family. But you have to know that tumor generation in the belly is related to secretion of gastrin. So does that mean that people with pelvic, I'm so sorry, you guys. I keep saying pelvic because I'm an OB nurse, and that's what I deal with. Peptic ulcer disease are at higher risk for gastric cancer. Let's see. Gastrin stimulates hyperplasia of the gastric epithelial cells, whose growth may ultimately result in a gastric carcinoid tumor because of the hyperplastic adaptation of the cell. Also, these can cause fractures. By reducing acid secretion, it may decrease the absorption of calcium, and so it can promote osteoporosis. And so if we're talking about the elderly, we have to be very careful, and we have to keep taking, their bone density tests and their calcium levels. These medications also, and I just found this out recently, increase the risk of pneumonia. Especially Prilosec decreases gastric acid pH, which promotes bacterial colonization of the stomach and the respiratory tract, just because they're similar cells. So we have to use very cautiously in clients at high risk for pneumonia. And of course, who would these people be? Our COPD patients, people who are immunocompromised, anybody that has an autoimmune disease that's on any type of steroid, and then of course our cancer patients that are on cancer medications. Proton pump inhibitor also has medication-food interaction with delayed absorption of these medications may occur if taken concurrently with Prilosec, ampicillin, digoxin, iron. And you can see antibiotic. What are you using it for? We don't want delayed absorption. Digoxin is a heart medication. We just learned about it. It's with the inotropic properties. Iron for anemia. And then again, another, what's this one used for? Oh, antifungal. This is an antifungal drug. So allow at least 2-hour intervals between these medications and Prilosec. So what I would do, because how are you going to remember that? I would just know that if you're giving Prilosec, that we shouldn't be giving it with all the other medications. It should be given separately. Okay, nursing interventions and client education. We can't crush, chew, or break the sustain release capsules. Client may sprinkle the contents of the capsule over food to facilitate swallowing if they can't swallow, because a lot of these are in big capsules. Client should take Prilosec once a day prior to eating. Protonics can be administered IV now. Notify doctor if any signs of obvious or occult bleeding. That's the big thing throughout the gut, is the bleeding. And then let's talk about sucralfate or Carafate. It's a mucosal protectant. It is effective anti-ulcer medication, promotes ulcer healing by creating a protective barrier against acid and pepsin. It has no acid neutralizing capacity like our H2 antagonists or our antacids, and does not decrease acid secretion like our PPIs. It's a viscid and very sticky gel that adheres to the ulcer crater, creating a barrier. It's almost like putting a Band-Aid on it, or Vaseline, like Vaseline on your skin. And to back diffusion of hydrogen ions, pepsin, and bile salts. It doesn't let those go through. Attachment to the ulcer appears to last up to 6 hours. Okay. They're very difficult to swallow. It's a giant pill, very large pill. It needs to be taken with a ton of water. The larger the pill, kind of just a general, what do I want to say? A general rule, the larger the pill, the more water you have to drink, no matter what it is. Interferes with the absorption of a lot of other drugs, but does not if it's taken 2 hours prior to the other drugs. So again, Prilosec on the other slide, this one, once a day prior to eating, and then this one, same thing. So take 2 hours prior to the other eating and drugs. Dilantin, theophylline, digoxin, warfarin, Cipro. I mean, there's a ton of drugs that don't do well with this. So all you have to remember, because it's like the mucosal, it is mucosal protectant. It's like a Vaseline on a skin-chafed rash, that we have to put it on at least 2 hours so that it can do some work. Otherwise, what's the point? And what's it used for? Acute duodenal ulcers, GERD, and gastric ulcers. Should not be administered within 30 minutes of it. Again, it's just going to interfere with it. You want this to attach to the ulcer and then just leave it alone. Instruct the client that this medication should be taken on an empty stomach, especially this one, because we know what we're going to do with it. Instruct the client that sucralfate should be taken 4 times a day, 1 hour before meals, and again at bedtime, or even 2 hours before meals. I think your book said 1 hour. And at bedtime is the best time, because it can just, sit there and work for us. Can break or dissolve the medication in water, but should not crush or chew the tablet, as it is very large. All right, I will do the third one on the next slide.